start?
Yes, please.
So thank you for the invitation. So I guess my topic was the novel umbilical cord allograft in preventing the hypertensive phase in the AGVs. So when the trap fails, we have the options of to restart the AGMs or to plan for repeat trap in different quadrant, or to plan for a tube, and to plan for a TSCVC if everything fails. So we know the indications for the GDDs, like different difficult glaucomas, like the neovascular glaucomas or failure of traps and different other difficult glaucomas. And the GDDs have evolved for a long history from 1906 to the recent inventions like the Amit clear path and the Paul implants. So hypotony is one of the difficult challenge in the post-implant surgeries, and different implants like the valved and non-valved implants, they have their different clinical courses as far as hypotony is concerned. The challenge of the hypertensive phase comes after the initial hypertensive phase is over. The hypertensive phase is characterized by a huge cyst, thick bleb with IOPs of more than 21 in the first 3 months after surgery. And it is like a kind of analogous to the tenon cyst of trabeculectomy. It's a thick cystic bleb, and the incidences can be as high as 60 to 80% after the implant surgeries. The different risk factors will be there. And the problem is that we are again back to square one, meaning that we need to again restart the medications. And a significant part of these patients can also be converted into a failure. Just to discuss one short case report of a 10-year-old girl with a Sturge-Weber syndrome. She had a refractory hypertensive phase following the 2 implants. The 2 implants were placed in the eyes with supratemporal and infratemporal quadrant, but the IOPs didn't come under control. So planning for a TSCVC. So the management of hypertensive phase includes a lot of options like the intra-op Tenon's capsule resections to the amniotic membrane, or post-op steroids, digital massage, but none has been like proven conclusively except the post-op, the prophylactic medications. So post-op prophylactic AGMs acts as a medical ligature to prevent the initial flow of the inflammatory aqueous. It is proven to be useful in preventing the hypertensive phase as well as to reduce the height of the hypertensive phase. So the AGV slicing is also one good interventions to cut the valve into a non-valve implant, and the in vitro studies are there, but in vivo studies are not yet been done. So coming to our discussion today, the novel umbilical cord allograft. In the studies, initial studies have done by Dr. Aparna Rao, and she had shown that around 34 eyes where 6 months follow-up, there's good initial outcome of good success rates in reducing the hypertensive phase. So it's a very simple procedure. Umbilical cord allograft is fashioned into a small piece around 3 to 4 mm in the dimensions, and it is to be just slided over the valve area beyond the scleral patch graft. So it will stay there, and followed by simply closing the conjunctiva with the atovehicral suture. So a simple technique by placing the umbilical cord allograft, and this will be the bleb height will be less, the IOPs will be low as what we expect. So coming to our results at a 1-year follow-up data, so we had 44 cases compared to 38 control eyes, and the final IOP and the number of medications were lesser in comparison to control eyes, but the number of eyes who need repeat surgeries as well as the number of eyes with high hypertensive phase were not improved by the use of this umbilical cord allograft. So the Kaplan-Meier survival curve also showed that the eyes with this particular allograft didn't score better than the eyes without that allograft. So ultimately, the results are not that impressive one, but this is the promising technique, and we believe that if we tweak the technique to some extent, we can have better results as time goes by. So to conclude, the road after implant surgery is not always smooth. There will be ups and downs, and best of luck driving. Thank you.
Thank you, Dr. Avik. Sir, any comments on that?
Is it commercially available?
Yes, it is commercially available.
Okay.
Thank you.
And how many can you harvest?
So one piece of this particular allograft is available, and it is priced around 5,000. So you can have make 4 pieces.
Cut it, okay.
Yeah, cut it.
You can use it in 4 patients.
Yeah, 4 patients.
And how do you store it?
It is stored in the MK medium.
Thank you.